Swayam Prabha. Digital India. Educated India.
So in today's lecture, we'll talk about a separate group of lung diseases which are very important. So till now, all of us know that lung diseases actually they are classified depending on their etiological factors. Okay, what causes it is, but there are separate group of lung diseases which are divided or classified purely based on spirometric analysis. So what are those? Though these lung diseases broadly they call it as diffuse parenchymal lung diseases, which are chronic and non-infectious nature. So this is chronic. So these conditions they have long duration and they are diffuse in nature. That means they involve both the lungs, all the lobes and both the lungs. That's why they call it as diffuse. They are not acute. They're usually chronic. The longer duration, symptoms, signs and symptoms will have longer duration, diffuse, and they are non-infectious. So they are not caused by any infectious agents, non-infectious etiology. So all these lung diseases they club together, and depending on the spirometric analysis they have divided this broad category into again two main categories. What are those? One, depending on the lung physiology, if the lung physiology shows obstructive nature, we call it as obstructive airway diseases. Obstructive airway diseases, obstructive lung diseases. The name itself indicates there is some obstruction to the air passage. Obstruction means there should be some narrowing or some decreased lumen anywhere in the tracheobronchial tree. So that means obstructive lung diseases involves mainly the tracheobronchial tree. Okay, the disease can be at any level. It may be of the trachea, it may be bronchi, bronchiole, or sometimes it may have a alveolar respiratory bronchiole also. Respiratory bronchioles. So any obstruction, nothing but a narrowing of the tracheobronchial tree causing obstruction to the airways. They all categorized as obstructive lung diseases. Second one is restrictive lung diseases. Restrictive lung diseases means lung will lost its elastic recoility. So restrictive means their lungs alveolar parenchyma will not expand. So there is problem with the alveoli. In the alveoli, tracheobronchial tree will be essentially unremarkable. Problem was in the alveoli. So alveoli cannot expand properly. Air entry. So I will tell you the difference between these two. So main classification is depend on spirometry. Spirometric analysis. That means it shows the lung physiology. Spirometric analysis shows the normal lung physiology. Right? If it shows obstructive, the two most important spirometric parameter that you should know is forced expiratory volume in 1 second by functional vital capacity. Okay, if it shows obstructive physiology, that means there is obstruction in the tracheobronchial tree. Elastic recoility of the alveoli will be essentially normal, unremarkable. So what happens? Air will enter the alveoli. If you want to expire air during expiration, because of this narrow of this tracheobronchial tree, the forced expiratory volume, you have to exert yourselves to expel the air. So forced expiratory volume will increase because of increased resistance. Right? Whenever there is a narrowing, you will have more resistance. So forced expiratory volume, that is the amount of volume you will throw out or you will expire in 1 second. So that will be increased. What happens to the lung capacity? Lung capacity or vital lung capacity, it will be increased. How it will be increased? On each expiration, small amount of air gets accumulated in the lung parenchyma. Then next cycle, again small amount of the air will accumulate in the lung parenchyma. Hence, the vital capacity of the lung will be increased. And forced expiratory volume will also be increased. That you should remember. In restrictive lung physiology, the airway, tracheobronchial tree, everything will be normal. Air entry will be normal. Problem, where is the problem? It is problem in the alveoli. So alveoli cannot expand. So what happens? When the alveoli cannot expand, the vital capacity of the lung will be automatically, it will decreased. And on top of that, the forced expiratory volume will also be affected, but usually very mild. Forced expiratory volume will be affected. It will increase or it is mildly increased. So these two important things are subdivisions of chronic, non-infectious, diffuse lung diseases you should be knowing. Main classification is according to the lung function, spirometric analysis. If it shows obstructive etiology, that means narrowing of the tracheobronchial tree anywhere from the trachea, bronchi, bronchioles, including some diseases affecting the respiratory bronchiole. Elastic recoility of the lung parenchyma will be essentially normal and remarkable. And what happens when there is narrowing of the tracheobronchial tree? Forced expiratory volume that you expire in 1 second will be increased, mainly because of increased airway resistance. Vital capacity of the lung gradually increase. On contrary, the restrictive lung diseases, tracheobronchial tree, airways, everything will be normal. Problem is alveolar elasticity will be lost. So vital capacity of the lung will also be lost. Okay, these two things you should remember. So in today's lecture, we'll talk about obstructive lung diseases. So what are the diseases which causes obstructive lung physiology? There are 4 more important disease categories that all of you should know. Okay, one is obstructive lung diseases. I repeat, obstructive lung diseases means it involves the tracheobronchial tree. Okay, what are those? 1, emphysema. Second, chronic bronchitis. Number 3, asthma. All of you know, are familiar about this asthma. Number 4, bronchiectasis. Right? These are the 4 individual diseases. If you see them in a prototypical form, that means if the patient is having purely emphysema, if the patient is having purely chronic bronchitis, these are prototypical forms. So then each individual entity will have separate a clear-cut clinical signs and symptoms. They will have clear-cut radiological features. Okay, but usually that will not happen. Okay, what happens? Especially these 2 parts, emphysema and chronic bronchitis, usually they overlap. Hence, these together we call it as chronic obstructive pulmonary disease. That is called as COPD. That means it includes both emphysema and bronchi. Asthma and bronchiectasis, they kept separately, and we will be talking about these 2 entities in the next class. So I will erase this. Before I'll erase, one important point I would like to highlight here is emphysema, chronic bronchitis, they are irreversible lung diseases. Bronchiectasis is irreversible, but asthma, why did they separate asthma? Because it is a seasonal variation and it is reversible etiology, right? This we'll talk about in detail in the next class. So we'll talk about COPD. Emphysema, chronic bronchitis, together we call it as chronic obstructive pulmonary diseases, right? COPD. Why they club together? What is the reason behind this? Is when you see the most common etiological factors in the development of COPD, either emphysema or asthma, it's clear cut. It is seen in all patients who are having heavy smokers. That means etiological factor is same. Okay, and what happens in both the entities? In emphysema, predominantly the alveolar parenchyma is involved. Bronchitis, as the name itself indicates, predominantly bronchi and bronchioles, terminal bronchioles are involved. But these two may also have some anatomical feature that which affecting the respiratory bronchioles. So common involvement of respiratory bronchioles, and because the common etiology, they club together, right? One thing you should remember, these two entities always overlap. You will never see a very clear-cut case of emphysema. You will never see a very clear-cut case of chronic bronchitis. So what happens when the patient presents to the clinical OPD? Predominantly, he might be having emphysematous symptoms, but partly of chronic bronchitis symptoms. Chronic bronchitis individuals, they may have predominantly chronic bronchitic clinical signs and symptoms along with that minor component of emphysema. They go hand in hand. Either some patient have emphysema predominant, some patient may have chronic bronchitis predominance. So hence these two are together called as COPD. All of you should remember this. So we'll talk about emphysema first. In COPD, we'll talk about emphysema. What is emphysema? What exactly? If you want to ask me the definition of emphysema, all of you can see there. It's a very clear cut. See, each word is very important. It is an irreversible. That means it cannot be reversed back, right? Enlargement of air spaces. Okay. There is a respiratory unit, alveoli. These spaces will be enlarged. They will be enlarged. Where it occurs only distal to the terminal bronchioles. We have terminal bronchioles here, which leads to a respiratory bronchiole. Respiratory bronchiole. Respiratory bronchiole leads to alveolar sacs. So any pathology, permanent dilatation below the terminal bronchiole characterized by dilatation of the air spaces, which is irreversible, and it is mainly due to destruction of these alveolar valves. Destruction of alveolar walls without, this is very important, without any obvious fibrosis. Without any obvious fibrosis. This definition is very important. I'll repeat again. Emphysema is defined as an irreversible enlargement of air spaces which are distal to the terminal bronchioles, accompanied by destruction of the alveolar wall without any obvious fibrosis. Okay. Ultimately, if you want to see either gross, radiologically or microscopically, what you will see? You will see the predominant enlargement of the alveolar sacs, air spaces, right? This is the definition. Let's see. I will just write one respiratory unit for your better understanding. We have till here, this is terminal bronchiole. This is leading to respiratory bronchioles, and we have alveolar sacs. This one respiratory bronchiole with a bunch of alveolar sac attached to it is called as one respiratory lobule or respiratory unit. Respiratory unit, or you can call it as lobule. So we'll concentrate only on this part. Depending on which part of the respiratory lobule is enlarged, we have 4 different classification as subtypes of emphysema. I have mentioned what are those 4 different subtypes: centracinar, panacinar, paraseptal and irregular. What are these? What is the meaning of these 4 subtypes? I will tell you in my next few slides. If you see the gross lungs of any patient who are affected with emphysema, how does it look? You can see there are important gross pictures, very beautiful gross pictures there. What all can happen? All of you know, one, there is a lung. If you put lot of air in it, what will happen? It becomes more and more voluminous. The volume will increase. Right. First gross examination, lungs will become puffed up. Volume will increase. Right. All of you can see. Once the volume is increased, what will happen? There is heart in the center. It will cover the heart. The heart cannot be visible. That is one of the indirect indication of voluminous lung. Heart will not be visible. When you dissect the sternum and mortuary in autopsy, when you take out the sternum, the lungs will be totally filled up in the thoracic cavity. Heart you cannot make out. One thing. Voluminous lungs. And externally, what happens when you put lot of air? Some of the alveoli, they get ruptured. So you will see blebs on the surface. You can see clearly in those pictures. You can see blebs. When you take a cut section, transverse section of this, you can see the multiple variable size cystic spaces in the respiratory parenchyma. All of you can see those pictures. Nothing but pleural bleb. They are present on the surface. Okay, they may be of variable size. So these are the typical gross features of emphysematous lung. Right. This is one more picture of Bulla Semphysima. When there is a gross voluminous increase of the lung along with multiple bullous-like structures, air spill spaces which are present on the surface, then that entity we usually call it as Bulla Semphysima. Bulla Emphysema. Why it is important? Bulla Semphysima, when they are present on the surface, they have more tendency to rupture into the thoracic cavity, leading to tension pneumothorax. So those are the most common complications of bullous emphysema. Right. In this picture, if you see, what can you see? Because of more and more air accumulation, all the alveoli, they get ruptured. You will see multiple cystic-like spaces in the lung parenchyma filled with air. All of you can see those different variable size cystic-like spaces. Right. So this is how it looks when you take the cut section of the lung parenchyma. If you see microscopic examination, there are 4 pictures for your comparison. On the left side, there is a normal lung. On the right side, on top, you have a emphysematous lung. All of you, without any explanation, you can make out normal lung, it looks normal. And when you see the emphysematous lung, all the air spaces were grossly distended, more clear. And even in higher magnification, the below mentioned pictures, they are on higher magnifications. Even you can see some of the alveoli, the wall, it has ruptured. Can you see? Some alveoli, there is a rupture of the wall. Because of more and more air collection, the alveolar wall will rupture. Once these alveolar rupture, adjacent alveoli, they combine together to form a big bulla-like cavity, air-filled cavity spaces. That's most important. This is how it looks. Are you seeing any obvious fibrosis or inflammation? No. Inflammation, if it is there, it is very minimal, secondary. But this is the clear-cut features of microscopic or histological features of emphysema. Grossly enlarged air spaces, no obvious fibrosis, and when you see in the higher magnification, some of the alveolar septae, they are ruptured because of air tension. Right? This is the microscopy. Now we'll come for classification. As I told you just now, emphysema, they are classified into 4 different subtypes. Right? One is centriacinar, panacinar, paraseptal, and irregular. Okay. What are those? Each one means. So you can see the picture. I'll draw here again. This is the respiratory bronchioles. Right? These are the alveolar unit. This is one alveoli, one alveoli, one alveoli. This is respiratory bronchiole alveoli. All of you understood? Centriacinar emphysema means there is gross dilatation involving only the respiratory bronchiole. Rest of the alveolar sac are essentially unremarkable. They are not dilated. There is marked dilatation only on respiratory bronchiole. Then we call it as centriacinar. Centriacinar emphysema. Why it is important, centriacinar emphysema? It is one of the most common, more severe form of emphysema that can be clinically manifested, and most commonly they are seen in heavy smokers. And when you examine these things, respiratory bronchioles will show loss of smoke related dust particles. It is deposited on their wall, respiratory bronchiole wall, leading it to proper gross dilatation of the respiratory bronchioles. And these bronchioles, when you see grossly how it looks on lung, whole lung, centriacinar emphysema more prominently seen in the upper lobes. That you should remember, upper lobes. I repeat, centriacinar means irreversible enlargement of only the respiratory bronchioles without any involvement of the alveolar sac. Number 1, this is centriacinar. Number 2, panacinar. So these two are very important, centriacinar and panacinar. Pan means the entire respiratory unit. Okay, entire respiratory unit, including respiratory bronchioles and alveolar ducts. This whole segment, right? This whole segment is enlarged. We call it as panacinar emphysema. Pan means it's not the whole lung. I am talking about only the respiratory unit. The whole respiratory unit is grossly dilated. We call it as panacinar emphysema. Most common cause of panacinar emphysema is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. Most common cause for centriacinar emphysema is heavy cigarette smoking. Okay, these two are very important and they are very serious. Number 3, paraseptal. Paraseptal. If you think that this is a respiratory unit, respiratory bronchiole is here, alveoli here, and here you have a septa, interlobar septae or the pleural cavity, pleura. If it is here, only the alveoli which are adjacent to the septa or pleura, they are grossly enlarged. Rest of the proximal alveoli, respiratory bronchioles, they are essentially normal. Then we call it as paraseptal emphysema. The most common complications of paraseptal emphysema is it can rupture into the pleura or it can cause tension pneumothorax. Most common cause of paraseptal emphysema, right? And this paraseptal emphysema, they are also seen whenever you have lung fibrosis. For example, I'll see this is the lung. If you have any fibrotic foci, adjacent alveoli, adjacent respiratory unit, they may show paraseptal emphysema. Then fourth one is irregular emphysema. The name itself indicates some alveoli, this part is involved, some alveoli, this part is involved, this part is spared. So multiple, you cannot classify in any of the other 3 subtypes. Then you call it as irregular emphysema, and this is most commonly seen in the fibrotic lung disease. Wherever you have fibrosis, adjacent respiratory units, they show irregular type of emphysema. All of you understood? I repeat, emphysema, depending on which part of the respiratory unit is involved, is classified into 4 different subtypes. Centriacinar emphysema seen in heavy smokers, predominantly upper lobes are involved. It involves only the respiratory bronchioles. Rest of the alveolar sacs will be unremarkable. Panacinar emphysema, both respiratory bronchioles and the entire alveolar unit will be grossly enlarged, seen in alpha-1 antitrypsin deficiency. In this panacinar, lower lobes are commonly involved. Lower lobes commonly involved in panacinar. Upper lobes in centriacinar emphysema. Third one, paraseptal emphysema, where there is enlargement only in the sulcus, pleura or any fibrotic foci. Rest of the respiratory bronchiole alveolar part of the alveolar sac will be unremarkable. Irregular, usually seen in fibrotic lung diseases, adjacent fibrotic lung diseases. Okay, this is the important classification of the different type of emphysematous. Let's see. So can you see there are two important pictures? On left side you have gross pictures and right side you have microscopic pictures. The upper picture shows a centriacinar emphysema. You can see the arrow mark there. Centriacinar means only the terminal respiratory bronchiole is enlarged. If you can see the adjacent alveoli, alveolar sacs, they are essentially unremarkable. The down picture shows panacinar emphysema. When you compare the upper picture with the downward picture, the whole of the lung alveoli are uniformly enlarged. So these are the two examples of centriacinar and panacinar emphysema. Okay, let's see. We spoke about definition. We spoke about the gross and microscopic findings. We spoke about the different subtypes of emphysema. What is the What is the pathophysiology behind this of emphysema? What causes emphysema? So in books there are two important pathophysiological process they have been explained. One is protease antiprotease mechanism. This is very important. Protease antiprotease mechanisms, and second one is oxidant and antioxidant imbalance. Oxidant and antioxidant imbalance. The imbalance between proteases and antiproteases, imbalance between oxidant and antioxidants, and any one of these or together they can cause emphysema. Right? Let's see one by one. All of you can see the picture over there. It is an example how the protease and antiprotease mechanisms causes emphysema. Normally, what happens? I'll just in normal individuals. This is R. Normally, what happens? We have liver. Alpha-1 antitrypsin will be secreted, synthesized and secreted from the liver. It will be circulated all over the body because lung has got very rich vascular supply, and this alpha-1 antitrypsin is deposited in the alveolar. If it is alveolar lining epithelium. Alpha-1 antitrypsin deficiency, it will be present. And all of us also know that lung has very tiny vascular supply, very dual vascular supply, very thin walled capillaries. The surface epithelium and capillary endothelium, they'll come in very close proximation for proper diffusion of gases. What happens? Along with the red blood cells, white blood cells will also pass it, right? So you have neutrophils, lymphocytes. So when the lymphocytes or neutrophils, especially the neutrophils, if they're passing through the small capillaries in the alveolar interstitium, they get activated. So some of the neutrophils, they produce proteolytic enzymes. The main function of proteolytic enzyme is whatever comes next to it, it will destroy. So if it is not properly controlled, so even the normal neutrophilic sequestration in the alveolar capillaries can cause damage to the normal lung parenchyma. Usually it will not happen in healthy individuals. Why? Mainly because of alpha-1 antitrypsin. It coats the lung alveoli. What are the proteolytic enzymes which are released by the neutrophils? It will neutralized by alpha-1 antitrypsin. Understood? So our lung is healthy. Normally there will be proper balance between alpha-1 antitrypsin deficiency, alpha-1 antitrypsin, that is anti-proteolytic enzymes, and proteolytic mediators, cytokines, which are produced by neutrophils. What happens when there is alpha-1 antitrypsin deficiency? Liver will not produce alpha-1 antitrypsin. Lungs will not be covered with alpha-1 antitrypsin enzyme. The main function of antiprotein enzyme is to neutralize the proteolytic enzymes which are secreted by the neutrophils. If it is not there, in alpha-1 antitrypsin deficient individuals, you will have more of proteolytic activity, no inhibitor. Hence, this proteolytic activity destroys the alveolar septae, leading into enlargement of the alveoli and mild inflammation, you can also see. So this is the protease antiprotease mechanism that has been explained. Okay, anything. The second mechanism is oxidant and antioxidant mechanisms. Oxidant and antioxidant mechanisms. What happens? As I told you previously, COPDs are most commonly caused by heavy smokers. So whenever you smoke cigarette contains numerous n number of chemicals. Nicotine is one of them. So what happens? Some chemicals, they cause chemotaxis. For example, nicotine. Chemotaxis means the inflammatory cells, neutrophils, what are all there in the circulation, they come and they get deposited in the alveolar lumen. Chemotaxis. And it also has many oxidative enzymes or chemicals, many oxidative materials which ultimately produces reactive oxygen species, oxygen molecule. Reactive oxygen molecule is very dangerous. It can destroy any of the normal body structure, any cells. So it produces reactive oxygen molecules. It causes chemotaxis of the lymphocytes and neutrophils. Once neutrophils comes into the alveoli, they also get activated. They produce more of cytokines. Cytokines like proteolytic enzymes. More of oxygen, reactive oxygen species, more of inflammatory cells, more of proteolytic enzymes. All these together causes damage. All this together causes damage to the alveoli, leading to emphysema. I'll repeat, COPD, emphysema. So this is the protease, antiprotease mechanism, oxidant and antioxidant mechanism. I'll give you an example. Let's see whether you understood this process or not. I'll give you a 3-patient scenario. One patient is of alpha-1 antitrypsin deficiency, right? One patient is heavy smoker. This patient will present to the OPD. This patient will also present to the OPD. And we have third patient who is alpha-1 antitrypsin deficiency and he is heavy smoker. Whom do you think the more severely affected? Obviously the last one, because there are two different mechanisms acting together causing severe damage. So these patients will present with the early age group and more severe form than these two, right? Okay. So these are the two mechanisms all of you should know. What happens radiologically? So what are the important radiological features of emphysema? Let's see. If you take chest X-ray of any patient who is emphysema predominant, what all can happen? As I told you, emphysema nothing but just air in the, more and more air in the lung. What all can happen? I showed you the gross morphology. The lung volume will expand. The same thing you see in chest X-ray. What all can you see? Hyper expansion of the lung. Hyper expansion of the lung. You can see in the picture radiology. When the lung is hyper expanded, what can happen? It pushes the diaphragm downwards. So diaphragm will become flattened flattened diaphragm, then it will covers the normal cardiac shadow. Number 3, cardiac shadow. So when the lungs expands, what happens to the rib? Ribs will be widely spaced ribs, and you will see less bronchovascular markings. Less bronchovascular marking. All of you can see those radiological picture. It is a clear-cut features of emphysema, predominant type of COPD, right? And if you see the lung, the whole lung will become full dark in color. Okay, this is one important features. Okay, and when you see these patients in a really, what will happen? Because of more air in the lung, the sternum will be pushed forwards, the bowing of the sternum, that you will see. So when you go to clinics, observe all those features. You just take out the x-ray, observe all these findings and try to learn by yourself. Okay, this is how the radiology it looks. How does this patient present? Clinical features, what all can happen? Small amount of emphysema is perfectly fine. The patient will not present with any type of clinical signs and symptoms. What happens when more than 1/3 or half or complete lung is involved? The patient is going to visit the OPD. So what all can happen? Patient will have difficulty in breathing. We call it as dyspnea. Difficulty in breathing. You will have weight loss. Weight loss, it is secondary. It is not truly related to the disease process. Weight loss, because of chronic disease, you will have weight loss when there is improper diffusion and also significant dyspnea, right? What will happen then? When you see the patient usually, our chest is conical in shape, right? Our chest shape is usually like this. So when more air is filled in this, you will see barrel shaped chest. When you see barrel shaped cells, so whenever there is air is collected, they are more prone for infection, recurrent infections. These patients will present with recurrent infections, and because of dyspnea, infection, then they cannot breathe properly. These patients may also come with cyanosis, low oxygen saturation, cyanosis, all the clinical signs and symptoms related to cyanosis, anxiety, and these are very important. When you do spirometric analysis in these patients, as I told you, all these patients will show obstructive lung physiology, right? What all can happen when there is cyanosis? Respiratory acidosis can happen, respiratory failure. These are the complications. Patient may present with respiratory failure. The patient may present with sudden onset of pneumothorax, tension pneumothorax, because of Bulla Semphysima. Okay, so these are the important clinical features that all of you should remember. So along with that, before I conclude about emphysema, let's see, there are some other important terminologies that you should remember. What is compensatory hyperinflation? Compensatory hyperinflation. What do you mean by this word compensatory hyperinflation? It is whenever, if you remember my atelectasis class, whenever there is a atelectasis, or whenever you remove a part of the lung or whole lung on one side, opposite lung, it automatically will expand. So it is just a hyperinflation. If you treat the cause, it will be reversible. Okay, hyperinflation is not amount to emphysema. Hyperinflation, that is just increase in air volume of the lung. If you take out the air, it will become normal. This important thing that you should remember. You should differentiate between emphysema and compensatory hyperinflation. Then one more important is obstructive inflation. Obstructive overinflation. What is this obstructive overinflation means? When you have a tracheobronchial tree, if there is any obstruction here, it acts like, for example, any kind of a foreign body, round foreign body, or any kind of a polypoid process in the tracheobronchial tree, which acts as a valve mechanism. Air will enter, but if you want to expire, this obstruct. So air gets trapped inside the lung alveoli each time you inspire. So air will enter, it will not go back. So this leads to overinflation. Okay, this we call it as obstructive overinflation. If you take out this etiology, it will become normal. So this entity also you should know. And then the third one is Bulla Semphysima. I recently showed you in my previous slides that when you have a bullous, big air-filled spaces more than 1 centimeter, 2 centimeters, which are present on the pleural surface, they are more prone to develop tension pneumothorax. So those we call it as Bulla Semphysima, right? One more important physiology of obstructive emphysema that I would like to mention, why there is more and more expansion of air below the obstruction. Normally, when you see the terminal duct alveolar, you can see that picture. There is always a connection between one alveoli with the other alveoli, right? There are three most important connections, normal physiological connections, all of you should know. What are? Canal of Martin, then canal of Lambert, then pores of Korn. So all those things, because when there is obstruction, air can enter from one respiratory unit to the other respiratory unit, causing inflation. Okay, these, what are those? Canal of Martin. All of you can see canal of Martin, nothing but one respiratory bronchiole is connecting to another respiratory bronchiole. One respiratory bronchiole is connected to the other respiratory bronchiole. This is called canal of Martin. Then canal of Lambert. One respiratory bronchiole is connected to the adjacent alveoli. Canal of Lambert. Pores of Korn, one alveoli to the other alveoli. So these three important normal communications that all of you should remember. Okay, and the last one is interstitial emphysema. Interstitial emphysema. What is interstitial emphysema? As we discussed previously, emphysema nothing. The more and more air gets collected in the alveolar lumen. What if the air collects into the alveolar interstitium? If the air gets collected in the alveolar interstitium, we use the word interstitial emphysema. How? Where it occurs? Whenever there is a forced damaged, a forced inspiration or mechanical ventilation, the alveolar walls will rupture and air can enter into the alveolar interstitium. Okay, along with that, one, mechanical ventilation, and any patient with whooping cough, when there is severe cough, so those also can cause alveolar rupture and entry of alveolar air into the alveolar interstitium. We call it as interstitial emphysema, right? So today we spoke about emphysema. What did we learn in today's class? We saw a chronic, non-infectious, diffuse pulmonary diseases. It is the broad category. Depending on the respiratory physiology, it is divided into obstructive and restrictive lung diseases. In obstructive lung diseases, what will happen? Forced expiratory volume in 1 second will be grossly increased. Obstruction will be present anywhere between the trachea to the bronchi, bronchiole, and even respiratory bronchioles. Elastic recality of the lung will be normal. In this, we have chronic bronchitis and emphysema. Together, we call it as COPD, mainly because most commonly respiratory bronchioles are involved in both these entities, and the common etiological factor is heavy smoker. And in today's class, we spoke in detail about emphysema. We learned about the definition of emphysema, what are the different types of emphysema, what are the pathophysiological processes that are involved, how the emphysematous lung look on gross macroscopic examination, how does it look on microscopic examination, how does these patients present to the clinical OPD, what are the complications, and finally what are the different subtypes of emphysema that we should know. One more important word I would like to highlight here. These patient, emphysema patient, when they come, because more and more air gets accumulated in the lung, they cannot breathe heavily, so they'll expire. They will expire manually. They'll use accessory muscles for proper expiration of the lung volume. So they will use pursed lip. Oof, oof. So these patients, they will sit like this. They will make their elbows stabilize so that accessory muscles are involved in the proper respiration. So these patients, because of more increased respiratory rate, their blood circulation will also increase. So when the blood circulation increase, they will have pink in appearance. They are called as pink puffers. Emphysema patients, they are called as pink puffers. Pink puffers when compared to blue bloaters that are seen in chronic bronchitis. I am going to talk about chronic bronchitis in my next lecture. Okay, pink puffers are these patients who are seen in emphysema, predominant emphysema I should say, and blue bloaters are predominantly seen in case of chronic bronchitis, right? Thank you.